So let's go back a few years. Life is always full of surprises. So here's a very early surprise. We started doing TAVR. We did not know very much about it. We didn't really know how well patients would do. But intuitively, it seemed that relief of the pressure overload afflicting the left ventricle would override every other concern we had, and in particular, would override the volume overload produced by mild aortic regurgitation, which was almost universally present in the early days. And as one of my colleagues said, you would think that after being decompressed, a ventricle would look at the operator through the patient's chest and say, "Thank you, doctor," even if there was a little bit of a leak. Well, of course, the truth isn't always as simple as it seems. And I show you the slide from Dr. Kodali's publication 7 years ago that really caught everybody's attention in a very unexpected fashion and really sent shockwaves through our field. And the observation from the partner trials was really very simply that even mild aortic regurgitation carried a higher risk of death than having no aortic regurgitation. We'd all seen patients with moderate or severe aortic regurgitation who did poorly after TAVR, and that really wasn't much of a surprise. But the cases that we and the core labs graded as mild aortic regurgitation in the very early studies also did poorly, with an increased risk of death. Now, interestingly, this finding was not replicated in the early CoreValve trial. So perhaps that was due to a difference between core laboratories. Perhaps that's because, as we believed, the self-expanding valves had continued expansion after the TAVR was performed, and we saw slight decreases in the degree of aortic regurgitation. Or perhaps that's because a patient who has aortic regurgitation after having a balloon expandable valve implanted has something different and perhaps more calcification, more vascular disease than a patient who's got a self-expanding valve with less radial force. So these were sources of conjecture. But if you looked at virtually every registry that was reported, the Gary registry, the France registry, the presence of a residual aortic regurgitation, mild or greater, carried about a 50% increase in the risk of death at 5 years. And in fact, last year we reported 5-year cardiovascular mortality in the CoreValve high-risk trial, comparing TAVR and SAVR. And in fact, at 5 years, mortalities were identical. But when one looked at predictors of mortality after TAVR, one saw, just as in the registries, that there was a 45% increase in the risk of death at 5 years if a patient had mild aortic regurg compared to no aortic regurg. So years ago, this was a problem. And we've seen things since to suggest that things haven't changed a lot. These are recently presented data from a little more than a month ago, looking at diastolic blood pressure after self-expanding valves and survival. So these are 1-year data. Diastolic blood pressure is a surrogate for aortic regurgitation. AR is certainly not the only reason diastolic blood pressures may be low. But what we saw was that the lower the diastolic blood pressure, beyond the point of about 70 millimeters of mercury, the greater the risk of mortality at 1 year. Not necessarily a tremendous increase in risk, but still something substantial. So is this association or causality? To me, that's always been the biggest question. Are patients who don't get a good seal with the valve, those patients who got more calcification, more rigid vessels, other things that might predispose them to to mortality or not? Well, from retrospective studies, it's very difficult to make that determination. And we would never randomize a patient to have more AR versus less AR, or would we? Well, that's wrong. We've actually done it. And let me show you how we randomize those patients. This is the Reprise 3 trial that I'd like you to take a close look at. This was a trial comparing the Lotus valve with CoreValve. Now, Lotus has a very effective sealing skirt, probably the most effective seal of all the skirted valves out there, and compared with the first generation CoreValves, which had no sealing skirt. So this was a trial of nearly 1,000 patients randomized 2-to-1 to Lotus versus CoreValve. Primary endpoint was clinical, but let me start by showing you a secondary endpoint. Well, let's start with this secondary endpoint. So, first of all, if you looked at Lotus versus CoreValve, the valve area for Lotus was about 12% lower than that for CoreValve. So there's a greater residual gradient and a greater peak aortic velocity. You might expect these things to be associated with an increased mortality. On the other hand, when one looked at paravalvular leak, there were tremendous differences in the frequency of more than moderate PVL, shown on the left here. CoreValve, nearly 7%, Lotus, approximately 1%. So a big difference in moderate paravalvular leak. And as shown on the right, the difference in mild aortic regurgitation, now shown in the gold color, is also very substantial. And take a look at Lotus. 82% of patients had no aortic regurgitation detected by the core lab. So for the Lotus valve, slightly higher gradients, slightly higher peak velocities, but much less aortic regurgitation. So in fact, I view this as a randomization to more versus less aortic regurgitation. So this is a great probe to test whether the association is causal or associative. And in fact, when you looked at the clinical endpoints, the primary endpoint, which was a composite of death, disabling stroke, and more than moderate PVL, was clearly lower for the Lotus valve. But if you take a look at cardiovascular mortality, it trends to be a little lower with the Lotus valve. Stroke, a little lower. Combination of cardiovascular death or disabling stroke, significantly lower. So this is not proof positive, but it is a randomized probe that suggests that there is a causal relation between residual aortic regurg and cardiovascular events, specifically mortality. Now, why might that be? Well, I'm the first to say I don't really know. But when you look back at the literature, you'll find this. And this is a very interesting paper. It turns out that this was written by a number of people who were my mentors at my prior institution. And these guys were very interested in hemodynamics. So what they did is they examined a couple of patients who had surgical AVRs for aortic stenosis, big, thick, non-compliant ventricles, and developed postoperative aortic regurgitation. And what you can see in this particular pressure volume pressure relationship is that ejection fraction and stroke volume are both improved. The pressure volume relation based on myocardial stiffness is unchanged after surgery, but even a very small amount of aortic regurg, here 15 mils per meter squared, increase in left end diastolic volume caused the PA pressure to rise, the PA wedge pressure to rise to more than 20 millimeters of mercury, and was enough to put the patient in pulmonary edema. So one hypothesis is, well, you've taken someone with a non-compliant rigid ventricle, now given them a volume load, and as a result of their pre-existing AS and the changes it's caused in the ventricle, they can no longer handle even a small volume load. That's one hypothesis. Here's the other hypothesis. Maybe it's the things we do to these patients. So here's a patient with aortic regurgitation who's not going to appear on the 1 or 5 year survival curves. And that's because this patient never made it out of the cath lab. The video won't play, but this patient was left with, I would say, a strong, mild aortic regurgitation. The operator decided that he needed a little bit more volume to expand the valve. And in fact, what the arrow points to is an annular rupture, which was fatal. So maybe it's the things we do to patients. Here's another one. This is a recent low-risk patient. We implanted a 34 millimeter CoreValve. We weren't very happy with the degree of aortic regurgitation, and this patient was very calcified, as are most patients with residual AR. We post-dilated this very aggressively. We used a 28 millimeter balloon, still weren't happy. We implanted a second valve-in-valve, not shown here. Had a lot of trouble getting that valve into place. Ultimately, we landed it about 2 millimeters deeper than this valve. Had no aortic regurgitation. The patient left the lab very happy, but we didn't, because the echo that we did as the patient left the lab showed that we had dissected a large piece of calcium from the non-coronary cusp of the aorta down to the anterior leaflet of the mitral valve. And you can see, I unfortunately do not have the echo, but you can see this piece of calcium swaying in the breeze. So I don't know what that means for the long term. Patient left the hospital on day 2, very comfortable with no aortic regurg, but there's still this dissected piece of calcium that we're worried about. So maybe it's the things that we do to these patients. So does this problem still exist, or is it mostly a matter of history? Well, I think the answer is that it's still here. And just to go through things very quickly, we've seen as the valves have evolved, the degree of paravalvular leakage has become reduced, is still not absent. It's still present in the TVT registry for large self-expanding valves. Mild aortic regurgitation shown in blue here, more than 35%. And if you look at the low-risk trials, this is the one thing that wasn't even brought up in the discussion when these trials were presented. If you look at PARTNER, if you look at CoreValve, 28.7% mild aortic regurg, 36% mild aortic regurg, combination of old and new generation valves. It's still a concern. And if you look further at the meticulous screening data the PARTNER investigators presented, you'll notice that there was anatomic exclusion in about 1 out of 5 patients. One would imagine, without having been privy to the actual cases, that these are largely related to calcification. So I think that even with good selection, we still see significant aortic regurgitation. And if one looks at expected survival of patients with bioprosthetic valves, especially now that we're dealing with low-risk patients, we're looking at patients in the 70 to 75-year-old age range who've got a projected 10-year horizon, and may even be longer today. So I think it's still an issue. I don't think we can say it's something that's passed. I think it's still something that's going to need to be followed very closely. And I think if you look at the data that were most recently published by the group at Mayo Clinic, there are data to suggest that if you follow patients long enough, it turns out that even our current recommendations for when to operate in the presence of aortic regurgitation may be too conservative. And what these guys did is they looked at patients with class 1 indications for surgery for aortic regurgitation versus patients who didn't have class 1 indications but went for surgery anyway. And if you look at survival, the patients who didn't quite meet class 1 indications, that is, whose aortic regurg was not severe enough, had much better 5-year survival than patients who did meet the current indications. So I think 2019, yes, Unfortunately, residual aortic regurgitation is alive and well and is still a problem. We have yet to determine whether it's a major hurdle, but I think every one of us in this room is going to have to keep an ear open to that because we may yet be surprised. Thank you.
Congratulations, Professor Kleiman. Do you think that the disadvantage of the CoreValve in terms of the mitral regurgitation over the Edwards valve has a trade-off, and the trade-off could be that the Evolute has a greater valve area? Also, in the latest two trials, I found a little bit disturbing again the paravalvular regurgitation incidence in the Evolute.
I think there are going to be trade-offs. I would bet, first of all, the one thing I should have talked about is that it's very difficult to assess aortic regurgitation after a TAVR, just because there are often multiple jets, they're not parallel. Echocardiographers have a tough time. I'm not sure that MRI is as precise in this setting as it's said to be. So I think the bottom line is there is going to be a trade-off, and I would bet that when we have enough data with enough variety of patients and enough follow-up, it's probably going to vary from one group of patients to the other, depending on how thick the ventricle is to begin with, how large the ventricle is to begin with, how good or bad the systolic function is to begin with, how critical those few millimeters more or less of gradient will be.
Thank you. Dr. Dimitriadis, you have a comment? Short comment.
Excellent lecture. We'd like to thank you for providing us all the latest data and your work on that. Going to lower risk patients, that means also patients who have longer life expectancy. So what's your thoughts about how we should assess paravalvular leak? And do you think that this long-term effect of paravalvular leak will definitely be something to tackle, to solve in major trials in the future? Because when you're talking about an 80-year-old, it's okay by paravalvular leak, but when you're talking about a 72 years old patient, this is something else, I think.
Yeah, so I think your first question is how to assess it. The problem is once you leave the laboratory, it's pretty much too late. We always tell ourselves, well, if this is a problem, we'll come back to the lab. We rarely do. And when we do, it's never as simple to repair as it is when you're in the lab. Now, how do we get around that? I think, first of all, in our institution, when we work on low-risk patients, they're all done under general anesthesia with TEE monitoring because we really do want to be more precise about assessing aortic regurgitation. There are newer valve designs. I don't know if I'm truly at liberty to discuss them publicly or not, that have some, I think, innovative approaches to reduce the degree of aortic regurgitation. I think down the line we may be, for example, also using lithotripsy to soften up the calcium to allow more complete valve apposition to the annulus. And at least one thing that I'm kind of excited about is there will be dedicated cath and MRI suites where we really can rapidly make good assessments of the degree of aortic regurgitation. Again, how to manage it once it's there is not always so easy.
Thank you very much for the excellent talk.
I have the honor to introduce Dr. Kapadia, who is